technologist does their best to ensure that the structures of interest, the dental-alveolar structures, are within that curved focal trough, which can be quite hard with the incisor teeth, as you can see. So, classical indication, trauma. Remember, when you look at trauma, the front of an OPG or a DPT is an AP, and further posteriorly, further posteriorly, it's a lateral. You need two views for trauma. A single OPG view is not adequate for evaluating mandibular or maxillofacial trauma. That's a condylar neck fracture, as shown on CT with intra-articular extension. So in terms of the approach, obviously check the patient details. Technical quality is particularly important in this examination. We have to check the dentition present. We have to look for common dental diseases. We have to look for bone pathology and temporomandibular joints in the review areas. So technical quality. Are there any radiographers in the audience? Okay. What?
Yes.
Yeah, okay, thank you. Welcome. So poor technique. Chin can be down and can be up, smiley or Whyte, I don't know, I've never really understood those terms, but anyway, low incisor roots are blurred because the lower incisors are outside the focal trough. In contradistinction with poor technique with the chin up, so the upper incisor roots are blurred. They're outside the focal trough, but the lower jaw has moved forward into the focal trough and the lower incisors are in focus. So that's chin up and chin down. They're out of focus. If the head is too anterior, all the incisors will appear too small, so they're minified. So if you're out in the focal trough and anterior to the focal trough, they're narrow and blurred. If the head is too posterior, the teeth will be magnified and also blurred. Okay, this is an ectopically situated lower left canine, and the deciduous canine, and the magnified incisors showing that the teeth are inside the focal trough. If you rotate the patient to one side, you will artifactually magnify on that side because you put that side of the mandible and maxilla inside the focal trough. So we can see this side is wider than the other, both the teeth and the bone, and maybe slightly indistinct. Not always, but maybe slightly indistinct. And this is true mandibular skeletal asymmetry with right condylar hypoplasia. Gross rotation may create all sorts of pseudo-lesions. So there was some concern about this sclerotic lesion to the left of the midline and a lucent lesion seen distal to that crowned premolar. When you look on CT, the patient's just rotated to the left. So you normally get sclerosis in the mandibular midline, in basal bone in particular, and the lucency was the mental foramen caused by patient being rotated to the left. If the tongue is not placed against the hard palate, and again, you try doing it, it's not that easy actually, occluding your teeth at the same time, you'll get this air gap superior to the tongue, between the tongue and the palate. In addition, if you approach the machine by slumping forward, you will get artifactual sclerosis from the cervical spine due to the ghost opacity. Motion artifact can be really tricky. Are these unusual little sessile protuberances from the inferior cortex of the mandible? No, they're not. They're due to the patient moving. Remember, it's a long exposure. They have a chance to move, particularly children, during the exposure. So, as we've said, it's a tongue stud, and we know it's the tongue. It's inside the focal trough. It's magnified and it's blurred, so it's inside the focal trough. It illustrates the physical principle. And that is an implant fixture supporting a crown. So the dentition present. Now, this is the bit that everybody loves. 4 quadrants. 1, 2, 3, 4. Okay, starting from upper right and going round clockwise to lower right. Number your teeth from 1 to 8 in each quadrant. And then add your prefix of your quadrant number. So for example, the upper right first premolar, 1-4, the upper left central incisor, 2-1, the lower left third molar, 3-8, and the lower right lateral incisor, 4-2. Deciduous dentition is slightly different. We have different quadrant numbers, 5, 6, 7, and 8, and you only have 5 deciduous teeth in each quadrant, so it's 1 to 5. So the examples, this is a patient with mixed dentition, meaning they have partially deciduous and partly permanent teeth. 5-3, the upper right deciduous canine. 6-5, the upper left second deciduous molar. 7-4, the lower right first deciduous molar, and the permanent successors in Whyte, 2-1 and 4-6. As regards the anatomical relationships, slightly different. We don't use anterior, posterior, or medial or lateral. We use mesial, meaning close to the midline of the mouth. Distal, meaning further posteriorly. Sorry, I'll just go back. Apologies for that. So distal further away from the midline, lingual meaning on the tongue side, or palatal in the upper jaw, and buccal meaning towards the cheek. So you may have a complete dentition, you may be partially dentate, or you may have no teeth, edentulous. You can have deciduous or permanent teeth, or have mixed teeth. And then there's other terms, edentulism, meaning no teeth, versus anodontia, meaning partial absence of teeth, which would be partial or complete. We have extra teeth, and we have unerupted or impacted teeth. So complete dentition present. Relatively unusual to have your third molars erupted and in complete occlusion. 8 teeth in each quadrant. There's only one way you can be confident of this, and this you have to count them. However much that may be distasteful to you, it's the only way not to actually shoot yourself in the foot. I mean, in a situation like this, you don't have to numerate the teeth. You basically say the patient's partially dentate, and they're permanent teeth, okay? You can see gross carious destruction of that crowned and tilted molar. And this is quite common when you lose a tooth, mesial to the tooth, it will rotate and tilt into the gap. Edentulous, and you can see that the infraalveolar canals are on the surface of the ridge. When you lose teeth, you lose the supporting alveolar bone, but not the basal bone. So basically this mandible consists of a thin rim of sclerotic bone, and the patient has been reconstructed with 4 implants supporting an overdenture. Mixed dentition is a mixture of deciduous and permanent teeth, approximately from the years of 6 to 13. The tip is to find the permanent teeth first, okay? So you find the first permanent molars and demarcate those in your mind. Find the permanent incisors and work out which ones are erupted, okay? Partial anodontia or hypodontia, mandibular second premolars, and the third molars are the commonest teeth to be absent. So here we have retained deciduous molars, 7, 5, and 8, 5, but no premolars to follow them. Partial anodontia, another commonly absent tooth, is the maxillary lateral incisor, and quite easy to miss these. Okay, so here we've got the canines erupted adjacent to the central incisors. Impacted third molars, as we see, we'll talk about that in detail. Of the supernumerary tooth, the commonest is in the upper jaw and in the anterior maxilla overlying the incisor roots. And this is given the name of a mesiodens towards the mesial or middle. Okay, they may impede the eruption of the permanent incisors. The problem is you have all sorts of artefact. These are the soft tissues of the nose, and they may simulate a supernumerary tooth. So you have to look very hard, and it may be impossible if the midline is not in focus for the reasons we've already discussed. And that's an over-erupted tooth. Again, it's continued to erupt because there's nothing to stop it erupting, because the lower third molar is absent. So mesiodens may be associated with cystic change because they don't erupt. So you can see M for mesiodens. The black lines indicate the cyst. There is displacement of the upper left central incisor, 1-1, We'll talk about dentigerous cysts, but they occur with unerupted teeth. Again, an extra molar called a distomolar because it's distal within the arch, impeding the eruption of 2-8. Some people call them fourth molars or a number 9. You'll hear them referred to as a 1-9, impeding the eruption of 1-8. Bilateral mandibular distomolars, not as common in the mandible as they are in the maxilla. And the impacted canine, or 1-3. Because the canine has a very high path of travel, it develops up near the nasal floor and comes down relatively late in the permanent dentition, then particularly with children with a smaller maxilla, it may go wandering or may not erupt properly and require a large deposit to your orthodontist and your oral surgeon to deal with that issue. So of impacted teeth, as I've said, third molar is the commonest, and then the maxillary canines. You describe the impaction relative to the occlusal plane. We'll talk about that in a minute. We'll talk about the root morphology, shape, size, curvature, and whether you think there's ankylosis. In the mandible, it's important to describe the relationship to the infalveolar canal, and in the maxilla to maxillary sinus. And you should look at the second molars to see if they're resorbed by the impacted tooth. So the patterns of third molar impaction, remember our mesial distal, you draw the occlusal plane, which is not a straight line, it curves up at the back. Then you draw a line along the long axis of that tooth and see what sort of angle it forms. So that's 90 degrees, that's erupted, it's vertically aligned, okay? That one is slightly distally angulated, so it's distal, and it's partially erupted, so it's impacted, so it's distoangular impaction. This is mesially tilted, so it's mesioangular impaction, and it's resorbing the root of the adjacent 3-7. And so again, you just basically have to play this game a number of times. Vertical impaction, distoangular impaction, 4-8. Horizontal impaction. You know, they may not be completely parallel. You just take your best options. So, you know, that's horizontal impaction. These are post-inflammatory calcifications, the palatine tonsil, very common, slightly out of focus over either ramus or the angle. Now these are a problem with impacted teeth. Is that crown, buccal or palatal, you know it's sort of sideways or oblique sideways, it's obliquely impacted, it's unerupted. If somebody wants to take that out, you've got to do a cone beam or a CT to actually determine where the roots are in relationship to the infalveolar canal and which way the crown is angulated. Just pointing out that the lateral incisors are absent in the maxilla, and you actually have a macrodont situation where the central incisors are huge. That's because there's developmental fusion of the central and lateral incisors, certainly on the right. So oblique impaction, as I've said, CT or cone beam clarifies. There's the buccal and mesial angulated crown. There's the apices projecting through the lingual cortex. So horizontal impaction of 3-3, it's gone wandering, and this is quite common with mandibular canines. They may be even across the midline. Okay, so there's 3-3. Bulbous fused roots of 4-8. Yeah, horizontally impacted. It's mesioangular to horizontal. But look at the infraalveolar canal. Adjacent to the apices, it's inferiorly displaced or posteriorly displaced and constricted. That's a very good tip. Particularly if it's also lucent, that the infraalveolar canal is intimately related to those apices. Okay, so in terms now of the common diseases, caries or dental decay, then we'll go through them, periodontal disease and periapical pathology. So caries is an attack on the enamel. The enamel's hard on the dentine, so the caries lesion expands into the dentine. It balloons into the dentine. There's a small lesion in the schematic diagram, the larger lesion expanding into the softer dentine, involving the pulp, and the tooth may eventually die. So why does it occur? Enamel defects, lack of topical fluoride, eating too many sugars, being fermented by Streptococcus mutans, and producing acid, which erodes the enamel, which then get into the dentine and then goes ballistic in the dentine. Now, Tomograms, DPTs or OPGs are not particularly good for diagnosing caries, particularly when small. It's usually clinically apparent, so don't try and be too clever. Intraoral radiographs, as performed by dentists, are much better and the optimum means of radiographic diagnosis of caries. Cone beam's poor at calling caries because of artefact, and you may overcall it on a DPT. You get MAC effect like you do on a chest X-ray. We'll just talk about a few restorations. So that's a small carious lesion. I know that because it was proven on an intraoral radiograph, but you know, you'd be kind of brave to call that. Okay, there's a bigger lesion in the dentine. So you'll see them in the dentine, you won't see them in the enamel. Again, we can see oh, I do apologise, I'll just go back again. Okay, so we've got extensive caries in the mesial aspect of 4-7, which has got a restoration, so that's called a recurrent caries. We can see the early periapical infection around the apices of that tooth, so that tooth is probably non-vital or dead. So we talk about dead teeth as being non-vital teeth. This is gross caries. I mean, nobody expects you to enumerate all the carious teeth. You basically say there are multiple carious teeth, and if there's multiple radiolucences around the apices, and there are several with these teeth, with several foci of periapical inflammatory lucency, something like that. Look to see if there's any complicating periapical inflammatory lucency, and I'll show a few examples of that. So multiple carious teeth, the more you see, the more you look. There's periapical inflammatory lucency in red, and it can be difficult to see in the maxilla. Now, radiolucent restorations, which tend to be older restorations in the anterior teeth, may be radiolucent. So you may think they're caries. That's what we call silicate. Other restorations are amalgam, which are the dense white ones, or silver restorations. And then in 3-5, we have a root canal filling. That tooth has been dead, the pulp has been removed, and it's been restored with a crown. And the root canal has been filled with a root canal material. So there's the radiolucent restoration. There's multiple of them, and most people won't walk around with a mouthful of carious anterior teeth. You know, it's upper-class bogans certainly wouldn't. So you don't do it. I mean, it's not just not the done thing. So, but there's recurrent caries in 2-6, and there's recurrent caries in 3-6. So periodontal disease is a more significant disease, not to the layman, but in terms of overall medical health. It's the opposite really of what you would think. So periodontitis is a biofilm infection, results in gingival inflammation or gingivitis, the soft tissues of the supporting tissues, followed by involvement of the periodontium, or the bone and ligamental structures of the teeth. And you can see the sequela and the plaque growth. You form a periodontal pocket, and it's kind of irreversible once it starts. So you have to look after these teeth. This is what plaque looks like. It's a sort of highly organized bacterial matrix with polysaccharides in it, binding them all together. And there it is there. And difficult to eradicate. So periodontal disease, mild, moderate, severe, horizontal or vertical, that's your classification. So this is mild, okay? And we'll talk about how you diagnose that in a minute, and it's horizontal, okay? It's paralleling where the ridge crest was. So we have enamel, which is dense, we have dentine, and we have then in the root the dentine becomes cementum. And the crestal bone should be no more than 1 to 2 millimeters below the junction of the dense enamel and the dentine. If it's below, then you've got early periodontitis, as illustrated in the diagram and on the radiograph. And around the root of the tooth, you have a black line, the periodontal ligament space, which is your ligament. It's like a bit of a shock absorber. And around that, you have dense cortical bone called the lamina dura. This is our distance, 1 to 2 millimeters. That's normal, okay? The problem is, it depends which way you look at it, and you're only looking at it one way on a panoramic radiograph. So if the tooth is tilted, it may change the alignment of that bone, and it may look like you've got a periodontal pocket. So the appearance varies according to the degree of eruption. Partial erupted teeth, it will look like there's periodontal bone loss in the tooth next door to it. The spacing of the teeth and the plane of visualization are all important. So it's not as simple as it sounds. And if you're not sure, don't call it. So that's looking into proximally between the teeth, and it's sort of V-shaped. Okay, and there's the explanation of tilted teeth and partially erupted teeth. So here we have a mixture of horizontal periodontitis anteriorly, and that tends to be the case. Vertical periodontitis, mesial to 2-3. We have vertical bone loss around 3-7 and between 3-8 and 3-7. And it's severe. Okay, it's involving more than 50% of the root height, so I would call that severe. And a deep periodontal pocket between the impacted tooth and 3-7. Gross periodontitis, okay? Now, eventually your lovely plaque biofilm may become calcified, and you may see it as little calcific deposits on the neck of the cervical region of the tooth or the root, and that's what your dentist or hygienist takes off with a scaler. Now, periodontitis can look very, very aggressive. The key, and there's calculus just to show you, I thought you'd like that. Periodontitis may almost look like malignancy, and look for one thing: if your roots are resorbed, it's periodontitis. If they're not resorbed, it's oral cancer in some circumstances, but it's a good guideline. So this apex, oh Jesus, okay. This apex is resorbed. This generalized periodontitis, it would be highly unusual to have this and a squamous cell carcinoma here as well. If you're not sure, say, please evaluate the mucosa. Okay, more calculus. So, you know, is it just tooth loss and your teeth become loose, your gums bleed? No. You've got significant increase in cardiovascular disease. You've got, it's really dangerous for pregnant women. And it's now been shown there's an increased risk of dementia with poor oral hygiene. So it's probably because of long-term bacterial colonization and stimulating an immune response, giving you a predilection for thromboembolic events. So periapical pathology, this is what happens when sepsis gets to the apex of a tooth. So it might get there via a dead tooth from the root, the pulp involving the root canal, or going to the apex, or it can get there going around the outside of a vital tooth by vertical periodontitis. Okay, so there's an example of both conditions. Okay, vertical periodontitis and periapical lucency in a dead tooth. So caries in the posterior teeth, or trauma in the anterior teeth, young kid falls off a bike, fractures the crown, infected pulp, goes to the root canal, involves the apex, and you get periapical inflammation around the dead tooth. Now, the root canal therapy, which we showed a few examples of, aims to remove the infected tissue in the root canal and the pulp chamber, leaving a root canal filling in situ, and some sequential radiographs showing the sequence of events. And you can see on the original image there was periapical sepsis. So, there's the periapical infection. So you can classify these, and most of the time it's a waste of time, okay? They're either black or white, they're lucent or sclerotic. There is a different, the only measurement that's been of value is the periapical cyst. If the lucency is over 10 millimeters and it's well defined on the corticated margin, it's probably an apical radicular cyst. But your proviso has to be that the tooth is dead. You only get an apical radicular cyst with a dead tooth, or when you remove the tooth, the cyst stays behind. It should disappear, but it may not, in which case you have a residual cyst. So periapical lucent lesions, they hard in the maxilla because of that air gap. Okay, so when we do a magnified view, we've got a heavily restored tooth with recurrent caries. We've got a periapical lucency, which is partially masked by the air gap. And then rarefying osteitis tends to be acute or subacute infection, where it's ill-defined, okay, and these teeth are going to be dead, so you advise vitality testing of the teeth, okay. More periapical inflammatory lucency with a carious 2-5, okay, mag them up, have a look. You'll lose that apical lamina dura, that white line around it, and you'll get ill-defined lucency in the bone with or without loss of trabecula. But the loss of the white line is a good sign. So a periapical granuloma, and again, you know, it's just words. It's a dead tooth. It's got a little white margin. It's less than 10 millimeters. So it's a granuloma or an abscess. Yeah, big deal. So, as I said, greater than 10 millimeters, think of a cyst, particularly if it's got a white margin and it's adjacent to dead teeth. So root canal therapy does not always treat the periapical pathology, and these lesions can grow and be very, very big. They can be relatively asymptomatic. This cortical hypertrophy at the margin of the jaws, the angles, is indicative of muscle hypertrophy, masseteric hypertrophy in people who grind their teeth. So large apical radicular cyst in a non-vital tooth which hasn't yet been root filled. Now, osteitis or inflammation in the bone adjacent to the apex of a tooth may be both lucent and sclerotic, okay, carious tooth, the sclerosis and lucency, or you can get diffuse sclerosis which can mimic metabolic bone disease or mimic sclerotic metastases, and look at the multifocal dental sepsis. So alveolar bone, particularly in the mandible, has a propensity for a sclerotic response. It's very, very, very common. Sclerotic lesions, as I'll talk later, around the apices of teeth are a nightmare, and they're given very peculiar names by dentists just to confuse you even more. Most of them have totally no relevance whatsoever. The commonest being a bone island, also known as idiopathic sclerosis or osteosclerosis. Vital tooth merges with the lamina dura, and if you do a CT on them or a cone beam, they're normally fused to a cortex. They don't, occasionally they'll cause root resorption, but the tooth's always vital. Then you can get a condition which occurs in elderly people where your roots become fatter and swollen due to high cementum being laid down. The significance of these is they may be ankylosed, and taking them out you might do something really nasty like fracture the jaw because they are literally erudited into the jaw. You've lost your periodontal ligament space, you've got a thick bulbous root which doesn't want to come out. Then you may get foci of new bone formation, used to be called cemental dysplasia, now called cemento-osseous dysplasia around the apex of a tooth. Okay, there's the mental foramen, there's our sclerotic opacity. Again, I don't think you should get too concerned about these. They are what they are. You can mention them, particularly if they're multifocal, but the thing you have to do is to check whether the tooth is vital. And you know, they either give you an electric shock through the tooth, or they'll put something like ethyl chloride on, which should produce a squeal of pain when the tooth is vital. If it doesn't, well, your tooth's dead, and you're facing serious financial consequences. So bone pathology, look, you know, you've got to determine what's real and what's not real. There's no point in saying no extradental abnormality if you don't actually look at the film, which I've seen very, very good radiologists do this. You remember you've got lucency and sclerosis, which may not be real due to the technique. You may have both. You have diffuse bone processes, widened intraalveolar canals, and if you've got any doubt, you can evaluate further with another technique. You often cannot give a specific diagnosis, okay, with a bone lesion. And remember, all the artifacts that you get overlying the posterior angle of the mandible and the ghost opacities from one side superimposed on the other, and the superimposition of anatomic structures. Pseudo lesions, you can get a very common one in the mandibular body due to the submandibular fossa and the change in shape of the mandible from distal to mesial. So that in the submandibular fossa you have the submandibular salivary gland, you get relative lucency, which is often confused as a radiolucent lesion. And particularly you get this in females who have osteopenia or osteoporosis. And it's a normal pattern. It'll usually be symmetric with the other side. And it's just below the tooth apices. So that's the submandibular fossa. I don't want to dwell on this, but you know, the oral pathology textbooks they're not fun. They're worse than general pathology textbooks, to be honest. So you don't want to know. So I'll talk about a few of the more important ones in my other lecture, but the TMJs, look at them, particularly in people with facial pain. You get a pretty good view in probably 75% of people with the TMJ. First thing you look for is articular surface flattening. That's called remodeling. And that normally means you've got a displaced disc. And you may see early articular surface irregularity, you may not be sure, but if the patient's got left-sided pain, you can always suggest another imaging test. We don't do TMJ tomograms. And as I've said there, obviously MR is the most optimal technique, showing a displacement meniscus, a joint effusion in blue, synovitis in grey. It's a joint, you know, there's nothing, apart from the disc, there's nothing that different about it. We can see that the condyles eroded on the FATSAT T2 image, and the patient's got pain because they've got synovitis and marrow edema. Okay, so TMJ. CT is a great technique. It was written up by Rudolph Boardinghouse and myself about 4 years ago in J. Miro. It's a fantastic underused technique, and it's our technique of choice for anybody aged over 35. It'll show you the disc where it's significantly displaced, it'll show you if the disc is recaptured, and it'll show you whether there's arthritis. So the review areas, just to finish up, maxillary sinus retention cysts, dentists get very excited about them. They'll call them mucoceles, and they'll think it's catching and various different things, and what should I do with it? And they get very excited if you don't report them, because they'll ring you up and abuse you. So 30% of people have retention cysts. They're rarely of any significance, and Gavin and I will talk about these, and you'll be fed up with them by the end of the afternoon. So there's another one. There's two actually. They're symmetric. Salivary gland calculi can be difficult because most of the time it's not actually going to be in the salivary gland or the duct. It'll be in the lingual tonsil or the palatine tonsil. These are actually submandibular calculi shown on ultrasound. In a different patient, we can see the calculus, and we can see the echogenic foci with acoustic shadowing on ultrasound. The thing that simulates is post-inflammatory calcification of the lingual tonsil. We've already talked about the lingual tonsil, and it tends to overlie or is seen just below the angles. Post-inflammatory calcification of the palatine tonsil overlies the ramus. So it's seen higher up, and we can see it again and confirmed on CT performed for another reason. Parotid calculi are extremely rare. Remember that most parotid calculi are not visible on plain radiographs. This was a patient who presented with facial pain, and you can see there's multiple tiny calcified opacities in the parotid gland, and we were able to make the diagnosis of Sjogren's syndrome on an OPG. So technical quality is important. Understanding your faults, standing dentition, impacted teeth, supernumerary and absent teeth, the common lesions, conditions, detect bone lesions, and then, if necessary, suggest another form of imaging. Look at your review areas. You look kind of stupid if you don't detect things which you would normally detect on a different plane film. That's what you're looking primarily at the radiograph for. And thank you for your attention.